My name's Shahid Ahmed, and welcome to this webinar on cardiovascular disease prevention. We're lucky on this webinar today to have three speakers, Dr. Yasser Javed, Nikki Holsworth, and Sean Warren. So Yasser, Nikki, and Sean, can I just basically ask you to introduce yourselves, please? So first, Yasser.
Hi, I'm Yasser. I'm a practicing GP in Northampton. I've got a specialist interest in cardiology, and I'm also got some strategic roles within sort of the remit of cardiovascular prevention in my region.
Nikki.
Hi, I'm Nikki Holdsworth. I'm the AF project lead with the AHSN in the northeastern North Cumbria.
Sean.
Hi, so I'm Sean. I'm the business director for UK and Ireland for AliveCor Kardia Mobile. Thanks so much for joining us today.
Okay, so thank you very much, everybody. And thank you, everybody in the audience, for joining us for this webinar on CVD prevention. CVD prevention is an incredibly important topic. Back in 1961, we used to have in England 261,000 deaths every year from cardiovascular disease. Now that had come down, and a couple of years ago, it was 137,000 people who had died from cardiovascular disease. Now these improvements are due to a number of things. So decrease in rates of smoking, improving living standards, but a very big and major cause of the improvements has been the management of cardiovascular risk factors by primary care. Despite the improvements that we've made, we still have well over 100,000 deaths a year from cardiovascular disease, and it remains our biggest cause of health inequalities. Therefore, it was a priority in our long-term plan, and Yasser will shortly be talking about our long-term plan ambitions around atrial fibrillation, blood pressure, and cholesterol. So, without further ado, I will now hand over to Yasser to start his talk.
Hi.
Over to you, Yasser.
Hi, sorry, yeah, we had some technical issues there. So let me share my screen. And hopefully you should be getting my presentation up.
Perfect, we can see it, thank you.
Wonderful, thank you so much, Shahid. It's an absolute pleasure to be here. So look, clearly in the NHS at the moment, we're practicing in a very unfamiliar environment, unique environment. And obviously, as a frontline clinician, I think like most of you, actually all of my consultations are now triaged remotely, either by telephone or video, and that poses its own challenges and considerations. But what's become increasingly obvious, certainly over the last few weeks, if not months, is that the excess mortality from morbidity and mortality from complications arising from suboptimal chronic disease management, in particular cardiovascular disease, are going to far outweigh, actually massively outweigh morbidity and mortality directly from COVID-19. And this is certainly something that we're being tasked with addressing at the moment, and in particular trying to address this huge unmet need in terms of diagnosis. There has clearly been a massive reduction in under-detection, I should say, of cardiovascular disease and its risk factors. Every cloud has a silver lining, and for me, the great opportunity that we have during this pandemic is how it has accelerated, actually turbo boosted the appetite for adoption of innovative technology to try and address this diagnostic unmet need. And so not only clearly does innovative technology potentially satisfy the requirement of detection in a safe environment, I think now that we've got experience of sort of utilizing technology in this regard, I think tantalizingly it offers in a post-pandemic world an opportunity to drive far more streamlined, efficient and leaner pathways that, far from being a compromise, are actually improving detection and in particular facilitating the early detection of cardiovascular disease. And I think this can truly leave a long-lasting legacy and a paradigm shift beyond the pandemic. Now, pre-COVID, we had an NHS long-term plan that had a great emphasis on cardiovascular disease. And clearly, these issues are not going to change simply because we're in the middle of a pandemic. And the reason why there's such a focus on cardiovascular disease is clearly it's the leading cause of dying in any Western population. But more importantly, it is one of the leading causes of dying prematurely in both men and women. And these, more so than any other cause of premature death, are actually largely preventable deaths. And it's not rocket science. The emphasis is on three important areas of atrial fibrillation, detection and anticoagulation, hypertension, again, detection and optimal treatment, and cholesterol, where there's a focus on more widespread use of lipid modification therapies in primary prevention, and also a focus on identifying those high-risk patients and families with familial hypercholesterolemia. And as I said, this isn't rocket science. We know these are areas that if we address them optimally, can massively reduce premature mortality from cardiovascular disease, and probably just as importantly, address this postcode lottery variation of care and outcomes that we often see in medicine. And actually, the reason why I'm so passionate about cardiovascular disease and why I fostered a specialist interest in this early on in my medical career was that I think more so than any other specialty, because the evidence base and the interventions are so impactful, you can add a tremendous number of years to life, as well as a massive amount of life to years by focusing on these type of areas. And as an example of the significantly increased morbidity and mortality from cardiovascular disease that we're going to see during the pandemic, let's show a CT scan of a fairly young patient. Again, this is not going to be an uncommon example, suffering a catastrophic stroke. You can see this large middle cerebral artery infarct. It's so large that it's actually causing a midline shift of the brain. If this patient survives this event, they're almost certainly going to spend their last few weeks or possibly months lying in a nursing home, not being able to speak, swallow, or move independently. Clearly one of the worst ways to actually succumb. And we know that atrial fibrillation actually has only come to light in the last decade or so, is actually the leading independent risk factor for having strokes, particularly these catastrophic type of strokes. In fact, it's much higher risk than, for instance, having hypertension, coronary disease, or heart failure. So AF increases your risk of stroke independently by almost 500%. And that's why there's such a focus on detection and management. So what exactly is atrial fibrillation? You could actually argue it's part of the normal aging process. So in a normal heart's rhythm, we call it sinus rhythm, there's this very regular synchronized electrical depolarization of the heart. But a third of us, that's how common AF is, will likely develop atrial fibrillation at some stage, whereby the electrical activity has become disordered, particularly within the atria. This can lead to stagnation of blood within the atria. Large clots can form. These can throw off to the brain and cause a stroke. So yes, it's part of the normal aging process, but it's so important. In fact, most of the emphasis for me is about proactive detection. So we know that age is your biggest risk factor, accelerated strongly by risk factors such as diabetes and hypertension. Why on earth we're not routinely screening for atrial fibrillation in our diabetic clinics, hypertension clinics, I genuinely don't know the answer to, because I see optimal management in AF and stroke prevention as being a race. Let's be proactive and let's hunt for the atrial fibrillation and manage it before our patients succumb to a catastrophic stroke. And this is an echocardiogram of someone who's just recently gone into AF. I just wanted to illustrate to you, if I can get my pointer to work, the size of the clot. It's a ticking time bomb. You get these clots forming. This is the left atrial appendage of the heart. And you can see this very unstable clot. It's about 3 centimeters in length. That can, at any time now, just embolize, break off, and almost invariably go straight up the internal carotid artery and into the brain and cause these catastrophic cardiovascular events. And not surprisingly, we've got clear data showing that AF strokes are far more likely to be devastating compared to other strokes, much higher morbidity, mortality, and disability compared to other strokes, twice as likely to be fatal, 3 times more likely to render patients severely dependent. And there's also just as much emphasis nowadays in hunting for those patients with intermittent or paroxysmal atrial fibrillation, because the data is fairly clear that these patients are almost at same or similar stroke risk to patients with more sustained atrial fibrillation. And of course, detecting intermittent AF or paroxysmal AF, which can be for very short bursts and quite infrequent, does pose diagnostic challenges, which again I think can be addressed with the adoption of innovative technology. Let's now also focus on the massive downstream costs of these strokes, not just NHS costs, so healthcare costs, astronomical, but look at the social costs. And we often forget the loss of productivity, and genuinely, I'm not sure we ever factor in the informal care costs. These are friends and family who now have to take time out to care for these patients. And of course, with the aging of the population, these costs are just going to increase rapidly with time, estimated to be in the region of 75 billion over the next 15 years. And because AF strokes are associated with increasing severity, much higher inpatient and outpatient costs, and more hospital bed days, we can see that the true burden to the NHS and taxpayer is huge, £22,500 almost over 5 years per AF stroke. But of course, there's a massive opportunity here that I don't think we can afford to miss. We know that purely in terms of detection, and this is pre-COVID, this is only going to be accelerated in the COVID world. We have 500,000 patients blissfully unaware that they have atrial fibrillation out there in the UK. And sadly, a very clear metric from our stroke audit data is that 50% of patients who succumb to an AF stroke, suffer an AF stroke, devastating cardiovascular event, were actually undiagnosed at the time of their stroke. In other words, stroke was their first presentation. And when we go through their notes, it's so obvious there were missed opportunities where we could have detected their atrial fibrillation, especially with adoption of technology. Diabetes clinics, hypertension clinics, flu jabs. These were opportunities that were potentially missed. And thankfully, there's so much technology out there that can help address this unmet need. And for me, the game changer, the real game changer in terms of technology was the AliveCor Kardia mobile 6-lead device. A lot of you will be aware of the 1-lead Kardia device, which has almost become mandated in terms of its usage in large parts of the NHS. But the 6-lead device, which is, Sean will probably correct me at the end, I think it's been out for almost a year now. I've certainly had mine for coming up to a year in September. It will be a year. This is the now FDA approved diagnostic quality, and that's the key. It's no longer considered a screening test. A diagnostic quality 6-lead ECG is no longer just a screen for who needs 12-lead ECG confirmation. So the difference between this device and previous iterations was that it has 3 electrodes. So if a patient puts both thumbs on the front 2 electrodes, there's a further electrode. I'm not sure if you can see mine on the webcam, but a further electrode on the bottom. If we place this anywhere on the patient's left leg, you've now got a phenomenal diagnostic quality 6-lead ECG. And with the 6-lead, you can glean so much further information, things like working out the axis. And of course, because you've now got lead 2, you've got a very, very good lead at working out the heart's rhythm, asking yourself whether there are any P waves and the relationship between P and QRS. I was so excited when I first got mine. I remember coming home late one evening, this had come through the post, that I felt compelled to actually test it out on myself at 1:36 in the morning, and thankfully revealed normal sinus rhythm. But pre-COVID, I can honestly tell you, not only was this probably the most important component of my doctor's bag, doing home visits, for instance, in nursing homes, etc., I used to carry this around with me at all times, because you never know when you're going to need it. And you know, I joke, people might take this as a joke, but genuinely the most fertile hunting ground for me for detecting AF was going to Asian weddings. Asian weddings, you've got this very almost lethal cocktail of lots of diabetes, lots of old people, lots of hypertension, lots of heart disease. And it was amazing how much AF we could just pick up in that sort of environment. And I think another really important bit of research we should be looking at is this European Society of Cardiology published registry-based study, which showed very relevant to the COVID-19 era, 1-year outcomes in AF during infections. We've known for a long time that infections can precipitate AF, but there's been this perception amongst much of the medical fraternity that infective-related AF is usually transient and potentially doesn't need significant follow-up or even management. But this study has clearly shown that once you've had one episode of infective-related AF, and we know that COVID-19 has a huge propensity for causing AF, even if that AF resolves, the patient's propensity for AF doesn't resolve. And within a year, 36% of patients were actually readmitted in AF, and that's just within 1 year. And importantly, we know that these patients are at considerably higher risk of stroke. So what this is really telling us is once the heart has had a taste of AF, it loves the taste of AF so much, it's almost certainly going to go back into AF and dramatically increase stroke risk. So more so than ever, we should be thinking of atrial fibrillation as simply a spectrum. Yes, initially patients might present with very short triggers, trigger-related AF like infection. That will almost certainly develop at a later stage into longer paroxysms of AF, ultimately persistent and then eventually permanent AF. But we now have compelling evidence that whatever stage a patient is in their AF trajectory, the stroke risk is significantly increased, and we really should be offering anticoagulation, one of the most effective treatments we have in medicine, relative risk reduction of 70%. You know, there aren't many interventions in medicine that give a 70% reduction in the risk of a cardiovascular event. That's what anticoagulation does. And really, we should be anticoagulating everyone, depending on their CHA2DS2-VASc risk factors, regardless of their trajectory, where they are in this trajectory. And I think this is where innovative technology like the AliveCor device come into play to help us detect AF at a much earlier stage to dramatically improve patient outcomes. As you could see with the NHS long-term plan, there's a huge emphasis on hypertension, because just like in AF, massive under-detection, about 50% in hypertension in the UK, and huge under-treatment. Very few patients, probably less than 50%, are actually treated to evidence-based targets. And just like with AF, we know that hypertension is a huge cardiovascular risk factor. Every 20 millimeters increase in systolic blood pressure, you're doubling cardiovascular mortality. But again, great evidence base for benefit for treatments. Long-term, good quality antihypertensive therapy hugely impacts on cardiovascular risk. More than a 50% reduction in heart failure, up to 25% reduction in risk of myocardial infarction, and a 40% risk almost reduction in stroke with early aggressive intervention. So now is the time during this pandemic, more so than ever, of reinforcing the virtues of remote home blood pressure monitoring. Not only is it going to be a lot safer than bringing your patient into the surgery, this shouldn't be considered innovative, because we've known for over 10 years, it's been in guidelines for over 10 years, both in NICE and European Society of Cardiology, that actually averaging out 14 home blood pressure readings is a far more accurate reflective of cardiovascular risk. That's what we should be doing in terms of clinical quality. Forget about patient safety. So now, more so than ever, I'm telling all of my patients at cardiometabolic risk, every 6 months, I want home blood pressure readings 14. So that means twice a day for a week. We'll average them out, and that's what I'm going to use to guide treatment. And the technology's been around for ages. Blood pressure machines. Make sure we reinforce the importance of upper arm cuff machines. The wrist monitors are just simply not validated for this purpose. And how else can technology like the AliveCor remote ECG recording device work? Well, it will massively, certainly has the potential for enhancing traditional pathways for patients with palpitations. And again, we're going to see a massive increase in this with the fallout from COVID-19. A lot of it's going to be psychological or anxiety induced, but we're going to see a lot of patients presenting with palpitations and a manifestation of this. Yes, the vast majority of these patients have no underlying significant arrhythmia that has a prognostic value, but a few of these patients, a minority, will have something significant and of prognostic value, which is why, of course, we end up referring most of these patients into secondary care, most often for Holter monitoring, and because of resource limitation, very often initially with a 24-hour Holter, which has a very poor diagnostic yield. There are typically long waiting lists associated with these referrals because of the limited resource, and then delays in results becoming available to GP. And we know from, data within individual hospital pathways that 75% of patients generally end up with repeat testing within 1 year. So as a summary, the current or certainly pre-COVID palpitation pathway could be very convoluted for many of our patients, usually involving repeated Holter monitoring, long waiting times for fitting. And remember, each fitting in itself will result in 2 visits to hospitals for both fitting and removal. And in an era where we're trying desperately to reduce footfall to hospital, this is a pretty inefficient and potentially unsafe way of delivering the pathway. And for me, I think remote ECG monitoring using things like the 6-lead AliveCor come into their own and really should hopefully end up retiring Holters for good, with the aim of revolutionizing the pathway to massively reduce time to diagnosis. Patients can actually do this at home in real time, send the report to their GP, hugely reduce, therefore, outpatient cardiology referrals, improve the patient journey, and no need really for repeat testing if it can be used generally as a Holter. Obviously, there's going to be massive downstream cost savings, remembering only a tiny minority of patients will actually need to see a cardiologist if something prognostic is captured on their device, and a reliable and easy to adopt solution for a primary care setting. And finally, I just want to end on a very important, an emotive issue. Too many patients are actually dying tragically from sudden cardiac death, and very often these are young patients with potentially many decades of good quality of life that's been lost. And the most common cause of sudden cardiac death is, of course, lethal arrhythmias. And this is a classic example of a lethal arrhythmia. This is a form of polymorphic ventricular fibrillation known as torsade de pointes. And we know one of the big risk factors for developing this is having an increased QTC interval. And we're becoming more and more aware of the importance of screening patients for this, because as your QTC interval increases, which is your time for repolarization, so it's how long your heart takes to recover from depolarization. We call that the repolarization time. And if that QT interval exceeds, approaching or certainly exceeds 500 milliseconds, more than halfway between the QRS complexes, then you could be in a situation when a patient starts to increase his or her heart rate, that you could get a QRS complex bang on a T wave. And if a QRS complex coincides with a T wave, you almost inevitably go into this torsade de pointes. Without ready access to a defibrillator, almost invariably these patients end up with a very bad outcome. In fact, most patients are diagnosed after their event. Let's have more emphasis using technology to try and identify, screen patients to actually prevent this. What are the causes of a prolonged QT interval? Well, many causes. Electrolyte disturbances are a common cause, so that must be one of our first screens. But by far and away, the commonest cause, genetics, play a very small role. Very few patients have a genetic cause, but it's drugs that are the mainstay cause. The vast majority of patients with a prolonged QT are on drugs that delay repolarization. They work on the potassium channels to delay repolarization. And classically, the ones that do it the most are the atypical antipsychotics, drugs like risperidone and quetiapine that we used quite frequently now because they're very effective antipsychotics, antidepressants, and we mustn't forget macrolide antimicrobials like clarithromycin and erythromycin, and also drugs like hydroxychloroquine, which could be relevant in the current era, that are often used in conjunction with some of these antimicrobials. We need to know the normal QTc cutoffs. So in adults, females have a slightly longer QTc interval than males. We don't know exactly why this is the case, but it does look as though female hearts take a bit longer to recover, electrically that is, not emotionally, from depolarization. So there's a slightly higher cutoff in women than men. And there are lots of algorithms embraced within the NHS. I'm not sure how many of them are actually adopted, but which reinforce the importance of QTc monitoring, especially when patients are on certain medication, in particular antipsychotic medications, but also for some of the other medications that we've discussed earlier, some of which are very relevant to the current pandemic. And the absolute red flag, of course, is a QTc of 500. No matter how effective a drug is, and I'm very reluctant to stop an antipsychotic in a well-controlled young schizophrenic patient, but if I see a QTc of 500, that's way too high risk for sudden cardiac death, and that really must be switched, stopped and switched over. And I think it's very reassuring that we now have, for the most prestigious, arguably the most prestigious guidance in cardiology, the European Society of Cardiology, for the diagnosis and management of cardiovascular disease during the current COVID-19 pandemic, great guidelines actually reinforcing the virtues of using handheld ECG devices, specifically mentioning Kardia Mobile 6 lead for having a high specificity for detecting these increased QTc intervals, and really should be considered the effective outpatient tool for monitoring patients with potential prolonged QTc. And it's now actually received expedited, accelerated approval from the FDA, again, for this purpose. So thank you very much for your kind attention. I hope you found that useful and maybe food for thought. I encourage you to answer or to ask questions related to anything that I've discussed. But my take-home points are, let's use this pandemic, this really unique environment that we're working in, as a great opportunity, because it's forced accelerated adoption of technology. Let's avail this opportunity to enhance the remote monitoring of our patients. And it's very, very clear, certainly from my perspective, from my experience, that far from being a compromise, some of these new remote pathways that are being developed will actually drive far earlier detection in a more efficient manner, which we know will lead to far better patient outcomes. In cardiovascular disease, the earlier you detect the condition and treat it with these great interventions that we have, the better the outcomes. And my great hope is that this will now leave a legacy in the post-COVID era as pathways become more streamlined, leaner, and more efficient, as well as, of course, being far more acceptable and convenient for patients. So I think we've got a great opportunity now to make a serious dent in this huge burden of avoidable catastrophic cardiovascular events. And we're going to see the legacy of this for many years to come. But we've got this opportunity to make a dent and avoid catastrophic downstream NHS costs, social costs. But of course, as a clinician, for me, the tantalizing prospect is to avoid these tragic human costs of all of these cardiovascular events. And let's really, this is my cry to really embrace this technology to help us add a tremendous number of years to life, as well as a massive amount of life to years. So thank you very much for your attention, and I'll hand back to our chair.
Thank you. Yes, a fantastic presentation. There was a particular comment that said this doctor's just got so much passion, so it's absolutely come over. I was struck by a number of things you were saying there, particularly around the social care costs, because I suppose the other thing that you're saying in that statement is it's not just the social care cost, it's the workforce that could be otherwise deployed to be doing other things if strokes, for example, were prevented. presented. And you really made the point about how important early detection and treatment of cardiovascular risk factors is. So thank you for your presentation. Now we're going to go over to Nikki Holdsworth. Nikki, over to you.
Hi, thank you very much indeed. So let me just get on the right place on the screen. Okay, here we are. So as I said in the beginning in the introduction, my name is Nikki Holdsworth. I'm from the Academic Health Science Network in the North East and North Cumbria. And today I'd like to talk to you about how we've worked to close the prevalence gap and the implementation and impact on AF detection. Some of you may not have heard of the Academic Health Science Network, and essentially we cover the whole of England. We are a connected network of networks that are regional based. We are catalysts for innovation, we connect partners across the sectors, we create the right conditions for change, we are a collective. Our continuing mission is to find, develop and support healthcare innovation through improving lives, saving money, driving economic growth. Now, as we've already heard, the priorities in the long-term plan are to prevent 150,000 strokes, heart attacks and dementia cases across England. And we've heard Yasser talk about the considerable health gains by improving detection and the reduction through treatment of cardiac events. We know that stroke is the fourth leading cause of death in the UK, with approximately 100,000 people having a stroke each year, and it contributes to 1 in 5 strokes in the UK, with an associated greater disability and mortality than non-AF related strokes. So the AF detection project, with that in mind, in 2017, NHS England commissioned the 15 HSNs across England to facilitate adoption of innovative technology aimed at reducing the incidence of stroke and increasing detection, closing the AF prevalence gap and increasing anticoagulation treatment rates. The national rollout aimed to understand the best approaches to the spread and adoption of pulse checking technology. 6,000 AF detection devices were distributed nationally within each HSN, and each HSN individually were able to decide on which technology they could use, and they could choose from one of 6. Over 95% of the devices chosen were AliveCor Kardia mobile single lead devices, with opportunistic case finding in a range of community and healthcare settings. The National AF team produced guidance on distribution, information governance and integration into local care pathways, with an online registration form for each Kardia account created that provided centralised data collection, which then enabled us to see who, where and how often pulse checks were being undertaken. The project evaluation was due to be published in late 2019. However, thus far it's been a victim of PERDA, then Brexit, and then not long after that, COVID-19. So as yet, unfortunately, it's not quite made it to the top of the in tray. So we're still waiting for publication on that, sadly. Within this project, there were many opportunities for opportunistic detection of AF in healthcare settings and beyond. Listed above are the areas within the North East and North Cumbria. However, other regions included devices in settings such as prisons, mental health services and nursing homes. The rollout allowed for the evaluation of each setting suitable for AF detection and determine whether it was low, medium or a high impact setting. While some settings may have netted a low yield in terms of detection numbers, they were often in areas with hard to reach patients or patients from BME communities that typically would not engage in a traditional healthcare setting. And therefore, undertaking a pulse rhythm check with AliveCor frequently acted as a valuable enabler and led to increased health-related interactions, conversations or activities without which this would simply not have taken place. So the national results showed an increase in AF prevalence from 79% in 2017-18 to 83.6% in 18-19. With the AF programme in the North East and North Cumbria, that started in 2013-14. And at the start of the local AF programme that we had in our region, there was a prevalence gap of 25,619 patients. This is all based on PHA modelling. The figures based on were based on PHE modelling, sorry. And in 2018-19, there was a denominator change for those figures. The AF prevalence gap then was shown to be 17,661, so still a significant reduction. However, if we'd compared like for like using the same denominators for 2013-14, there would have been a prevalence gap of 12,366. So therefore, over 50% reduction in the initial prevalence gap when we started the programme. The North East North Cumbria, depending on which denominator you use, found between 8,000 and over 13,000 new patients with AF. Significant. So the AF detection project in the North East and North Cumbria, that work had already started prior to the NHSE work that was a national piece of work. We had a local project prior to the national piece of work. We had a project lead in place. We already had started to build existing relationships. We were familiar with the AliveCor device and the Kardia app. And because of that, we chose to have 100% AliveCor Kardia devices, and we were allocated 374 devices from the NHSE allocation. We'd already started to overcome some of the barriers and issues. We produced a protocol. We prepared a training package, although this training package was reviewed and changed depending on who we were training. And we were slightly ahead of the curve when the national programme commenced. So the implementation in North East North Cumbria, we had a rollout started in January 2018 with the completion of all of those devices by 2019. The majority of those devices went to primary care. There were about 25% went to wider healthcare settings, some of which you've already seen on the previous slide. We offered face-to-face training in small groups, and we provided supporting documentation. All accounts were registered, and that was to enable us to track the usage and data. We issued a series of automated emails over the following 3 months after their training. Device usage was fed back to users and stakeholders, and we implemented a programme of reward and recognition in a peer-to-peer setting. Now, I appreciate the figures on there may be fairly small. Now, this data is by profession, and this data covers the NHSE national project. Now, you can see there's some variation in the detection rate in some of the settings, but we had some really high detection rates, such as in community cardiology settings or podiatry settings. The lower detection rates were certainly in the third sector, such as social prescribing, but as I've already said, the numbers of interactions were valuable interactions in themselves. Due to the success of the national programme in the North East and North Cumbria, we decided we would continue with the AF detection programme locally. We'd had increasing engagement from the wider healthcare system, and as such, we decided we would purchase a further 100 AliveCor devices. We agreed with the Academic Health Science Network in Kent, Surrey and Sussex to continue to collate the usage data beyond the NHSE project deadline. So from all of this work, what did we learn? We learned that timescales are easily underestimated. Everything takes longer than you think it will take. Building relationships was really important. And again, this goes back to timescales, that actually the time taken to build these relationships, again, can be longer than we think. And we need to get value from those relationships, and we need to value the relationships that we have. There's value in our networks. Essentially, project delivery is about people, and it's about the relationships that we have with those people. So when we build the relationship, we're creating our network. We needed to understand their barriers and how to remove them. And some of the common barriers that we initially came across was resistance to change and fear around the adoption of new technology. And it's interesting to note and reflect on what Yasser has said about how in this current situation, we've almost unilaterally been forced into adoption of new technology. In terms of training, to train somebody in the adoption of new technology really needs to be done in small groups. We had a very unsuccessful session with a large group of GPs, about 30 to 40 GPs. It really didn't work very well. We found that training in groups of less than 10 was better. There are some people who will adopt the technology and be very comfortable with it initially, whereas others are really quite nervous about it, quite anxious in the use of technology. The small group ensures that no one then gets left behind. It also allows time for valuable Q&As so that when people leave that session, they feel confident and competent in the use of the technology. Device registration was vital. Nobody left the training room unless their account was registered. And that allowed us to track the account numbers. And then through that, we were able to then track the usage data. Now, those who were part of the project were aware that we would be tracking usage data, and they did agree to their email address that was used to set up their account to be shared with AliveCor in order for us to track that data. Maintaining motivation and engagement. Now, motivation and engagement are often very high at the start, especially when you go to a GP practice with a new piece of technology or a new device that's free to them. They're all very excited and very keen to use it. However, once they leave the training room, their own priorities, pressures and demands will come into play, and gradually their engagement and motivation will decline over a fairly short period of time. And so in order to counteract that, we developed a series of 7 automated emails over a period of 3 months after training. And that was just to keep things front of mind. And we used various different formats. We had a talking head, we used infographics. It wasn't just a normal text email. We tried to make them a little bit different and a little bit interesting. Sharing data and information with our own team, and they were then able to understand the scope of the project, how the project was developing, and potentially be able to talk about it within their own networks. To share the information and data within the system, with the user, and that helped to maintain engagement. So within the system, that could have been within the CCGs, or it could be within a trust department, it could be with the cardiology outpatient team, whoever the system was that we were engaged with, and with the individual users, so they themselves could see the impact of their own work. The value of reward and recognition. This is a fantastic practice nurse in our area, and this is Carol. And we found that actually, you know, the NHS is flooded with targets and flooded with, you know, areas that we need to improve upon, things we need to achieve, and we need to do better here, and we need to do more of this. However, actually, when we looked at the value of reward and recognition, it really was kind of multiple in its positive outcomes. We found that the personal and team value in praise, so for the individual themselves, they found it incredibly, you know, powerful for them to be recognised, and recognition in their part in the patient health, but also their peers within their own CCG, within their own practice, or within their own trust area. It then inspired them to see the value of, you know, just doing a pulse check. The impact that this can have was really significant. So with carrying on with the AF detection programme within the North East and North Cumbria, this is the impact of the work that we've now done. So up until the end of June 2020 in the North East and North Cumbria, using AliveCor Kardia mobile devices, there have been 50,546 traces taken. That's been a possible AF detection of 3,408 patients, with potentially 170 strokes prevented, possibly saving 43 lives, and the financial cost of 7.8 million potentially over 5 years, looking at the health and social care costs. And that goes, you know, I was going to say it goes without saying, but actually does need to be said, the human cost. All the families, all those lives that have been, you know, impacted and saved because of this work that's been undertaken. Now, the data and the metrics and the stats are important, but I think I just wanted to remind you that it is all about the patient. The patient is at the heart of all of this. I'd like you to meet Mary. So Mary is a patient in one of the GP practices in our area. Mary had gone to see her GP, her local GP, who she had a good relationship with, just feeling a bit under the weather, very non-specific, nothing quite in particular. She didn't have the energy she used to have. She couldn't be bothered. She was a carer for her husband who had Alzheimer's, and she was really struggling with his care. And there'd been one or two incidents because she was really tired. And her grandson, she was involved in supporting her daughter to care for her grandson. And she found that she wasn't able to support her grandson and look after him quite so much because he was so small. He required a lot of attention and a lot of energy, and she just didn't have it any longer. This impacted on her daughter's ability to work, and her daughter ended up having to reduce the number of days that she worked, reducing the income coming into their household because Mary wasn't able to look after the grandson as much as she had been. Mary went to see a GP, undertook an AliveCor. It showed that she had possible AF, and then she followed the pathway, and AF was actually diagnosed, and she was started on anticoagulation therapy. And we received a fantastic email sort of message back from Mary. She was so grateful, incredibly grateful. She felt that it had really saved her life and changed her life. The impact on being able to care for her husband, the effect it had on how she felt about herself. She didn't feel old anymore. She didn't feel ill anymore. Being able to support her daughter, etc. It had a huge impact. And I think it's difficult sometimes it's not difficult. It's easy to forget the impact that we can have on the individual patients. And actually that impact can be huge. So within the AHSN in the North East and North Cumbria, there are various resources on the website. This presentation will be shared, and there are links to the AHSN website. We have a case study of the local project work that was undertaken, along with a project report. There's also various other AF resources on the website. I'd like to just draw your attention to a video that was undertaken by an HSN region, Wessex HSN. It's called Anticoagulation with Jack. It's an animated video, and it's available on our website or on YouTube if you just search Anticoagulation with Jack. It's a fantastic video for patients who've possibly had that anticoagulation conversation already with the GP, and for them to just look at, to remind themselves what anticoagulation means for them, and maybe to share with their family. So I just wanted to share those resources with you. And I wanted to just let you know that on the horizon in the next few weeks, there will be a national AF toolkit that will be available to anybody and everybody. And there are resources from all HSN regions across England that have had input into the national AF toolkit. So that'll be a valuable resource, a go-to place for you if you're wanting to undertake any work in the AF arena. That concludes our presentation. Thank you very much.
Thank you, Nikki. Great presentation. A few particular highlights from my perspective. It was great to hear the repetition of the long-term plan objectives of 150,000 strokes, heart attacks, and cases of dementia prevented. I mean, that's absolutely what we're looking to do. You highlighted the incredible importance of primary care and the huge contribution that primary care makes. And I think that can never go, that can never be repeated enough. It is really important for people to understand that. And actually highlighting a practice nurse, because they do such fantastic work, and each year they save thousands of lives in often an unrecognised manner. So I think it was great that you highlighted that. Before we move to questions, can I just ask both Nikki and Yasser about health inequalities? So cardiovascular disease is clearly the biggest cause of the gap in life expectancy, and just reducing cardiovascular mortality should help tackle health inequalities. But in the work that you've done to date, do you have any particular tips about how the work can be targeted so that it further reduces health inequalities?
So, yeah, I mean, for me, that was my major remit of being the cardiovascular lead of the East Midlands clinical network, is more so than actually improving overall numbers. We wanted to reduce that unwarranted variation. I guess it comes back to education and health beliefs as well, because I wasn't actually aware of how much. It's not just variation between you know, in terms of socioeconomic class, there's also a male-female massive divide actually in cardiovascular disease. There was this massive underperception. I didn't realize how big it was, that women don't seem to succumb to cardiovascular disease as often as men. So all of the education that we've promoted within our network has been tasked with trying to address that. And really, we want to also make sure that cost is not the overarching driver for local guidelines. I'll give you a big example with the DOACs. You know, the DOACs came along, and there was huge variation in terms of which CCGs would give ready access to DOACs for certain patients. You know, some CCGs were very early adopters, and I think what we've got to move away from, which will make the biggest difference, is moving away from just looking at cost, but moving more towards a value-based sort of commissioning proposition. It's very easy to say, oh, these interventions are very costly, without actually looking at their true value. And the beauty of cardiovascular disease, much more so than any other specialty, you're going to think I'm sounding very biased towards cardiovascular disease, but in cardiovascular disease, the initial investment in treatment diagnosis is much, much smaller than the downstream cost of the cardiovascular event. And I think once we move away from just silo budgeting, which, let's face it, I know we're not supposed to be silo budgeted, but it's still rife within the NHS. Once we move away from that and just stop looking at ridiculous things like arbitrary prescribing costs and look at total healthcare costs, I think that will help drive down unwarranted variation more than anything else, and health inequality. Because then we'll be in a situation, certainly in cardiovascular disease, where it's so easy to financially justify actually all patients, regardless of age, ethnicity, deprivation, and location, must have access to the very best available treatments, because that is going to be by far and away not only clearly best for patients, but the most long-term sustainable and cost-effective solution. So it's just changing the mindset within the NHS, of course, with heavy-duty primary care relevant education.
Thanks, yes. Actually, as you were speaking, I recalled a report that I'd seen earlier this week about the global impact that long-term conditions make on gross domestic product. You know what's good in tackling long-term conditions is actually good for the global economy as well. Nikki, any thoughts around health inequalities from your perspective?
From our perspective, what we have seen in our region is the value in kind of widening access. So, you know, in terms of working with Fire Rescue Service, who access elderly, you know, housebound and infirm patients who may not have another condition that feeds into any kind of healthcare system, but because they're deemed a fire risk, the Fire and Rescue Service are going to go into those homes. Now, those patients may not have crossed the healthcare path until they'd had some kind of significant event, or looking at areas where patients cross, you know, they touch the service in the widest possible sense, social prescribing teams, community pharmacies. You know, they may go to the GP once a year, but they may have, you know, a monthly prescription that they collect from the pharmacy. So the pharmacist may see them a lot more than the GP does. We've worked with PHE, where they've ran health promotion events in libraries. You know, we've worked in kind of areas of deprivation, but also areas of wellness. When people perceive themselves to be well, they then don't necessarily seek out any kind of test or assessment or choose to visit the GP or any other healthcare professional, because why would they? They feel they have no cause or reason to. So they may be they may feel a healthy person in the library. However, they may go to the library, you know, and find that actually they've potentially got atrial fibrillation or high blood pressure or some other point of, you know, care testing where has identified an issue that they weren't aware of. So I think for us, it was looking at where are the people and taking healthcare to people rather than getting people to come into the healthcare system.
Brilliant, thank you. And actually, as you were talking about the fire service, it reminded me, way back in 2003, my borough fire commander got his fire officers trained up as level 1 stop smoking advisors. So we have a huge workforce out there who are really keen to tackle health inequalities and have been for some considerable period of time. So, colleagues, We've got about 10 minutes left for further questions. So if you want to submit your questions on the chat box, we'll pick them up as they come through.
Shahid, I'm just going to chip in quickly from our side. I just want to say two fantastic or fabulous presentations from Yasser and also Nikki, and thanks for sharing as well. I think from a company perspective, we're extremely proud to support the academic health science networks in NHS England, especially supporting from a primary care and secondary care perspective. And in line with our mission, as well as the NHS long-term plan, we want to improve and increase early detection of cardiovascular disease to basically help patients live longer, and allowing our technology available to anyone at any period of time. As long as they have a smart device which they can connect, they can have a clinically medical grade ECG in 30 seconds in the convenience of their own home and share that with a healthcare professional. And coming back to some of the comments from Yasser and also Nikki, there's a huge under-detection currently in the country that we need to try and support and advocate technology to help with that. And interestingly, there was a recent publication from the European Heart Journal 2020, and during the national lockdown in Denmark, for instance, there's a 47% drop in the new onset of AF cases. So there's a big concern here, and we're allowing the ability for any patient or physician to communicate an an ECG, again, without potentially the requirement of a face-to-face consultation. So hopefully reducing the overall time period for diagnosis and intervention. That's our plan and that's our aim. So thank you for sharing your experiences today as well.
And can I just, do you mind me chipping in about making most efficient use of our time? If any, this pandemic has taught me more than anything else the value of clinical judgment and making every possible contact count. And I now think it should be considered, and this is going to sound controversial, but in my mind it's crystal clear. It's almost unacceptable to do a diabetic review, a diabetic foot review. You know, once you've got a diabetic foot, you've got micro and macrovascular disease. Your risk of having something like atrial fibrillation, which your heart's not going to be free of micro and macrovascular disease. If it's in your foot, it's in your heart. Why would we go to the effort of doing such a comprehensive diabetic review without screening for atrial fibrillation, particularly when the technology is there to get it so easily? So I think we've now got to have a mindset change, and we've got to think, are we really doing a proper holistic review of a diabetic patient, of a hypertensive patient, of a patient with CKD, without screening for things like atrial fibrillation? And once we get that mindset change, I think it's going to become routine, bread and butter general practice. And then we're going to see an explosion of detection of AF, and hopefully those patients that have a stroke as their first presentation of AF should now be classified as a never event or a very rare event. Because there are always opportunities to have picked up that AF, really. I've very rarely done a significant event review of an AF stroke where I've thought, this could not have been prevented. There's always opportunities to prevent.
There's some fantastic information, Yasser, as well, from a diabetes podiatry perspective, actually from the North Cumbria area as well, where I think the original identification was that if there were 6,800 people who could be detected with AF in England from a podiatry check, and 340 strokes that potentially could be saved. And coming back to your comment earlier about people working in silos in regards to budgets, well, if you look at the overall cost saving, that's potentially 7.9 million. So if you could put the ability of an ECG in the hand of every podiatrist in particular doing diabetic feet and looking at possible atrial fibrillation, there is obviously a desired interest, but a lot of the time it obviously comes down to funding and costing side.
If I can just chip in there, actually, on the back of what you've both just said there, we had this as an underpinning message, yes, when we worked in certainly primary care, was about making every contact count. And if the patient was sat in front of you and you were doing a diabetic review, a hypertension review, for any reason, if that patient was sat in front of you, you had the opportunity to be able to undertake something as straightforward and simple as a pulse check. And it became a, well, why wouldn't you, rather than why would you? And we did.
It's always got to become the default.
Yeah, we talked about that message of making every contact count, and that was an integral part of our training and delivery program to try and drive home that message. And just picking up on the Sean's comment there about podiatry, for example, we worked with a podiatry team in Sunderland to do exactly that. They were all given AliveCor devices. And they were asked, as the patient was laid on the bed having their diabetic foot screen undertaken, they were then also, they had their fingers on having a pulse check at the same time. So, these are really valuable areas in places where we can reach people. The other place that we found really valuable was flu clinics. And in a flu clinic, post a flu jab, not in the flu jab appointment, but post flu jab, that people could then, whilst they're sat waiting in the waiting room, would then be able to, they've got to sit there for a few minutes anyway, and you could have a healthcare assistant or even a member of the admin team would then do a pulse check, assessment on the patient whilst they're sat after a flu jab. And that was another area that we found a significant number of cases.
Yes, and Nikki, I'm quite conscious that we're not going to be able to get you to answer every question that's been posed, but there was also a bit of a theme around blood pressure and also a question about the role of the Director of Public Health in some of these conversations around health inequalities. So do you have any views around the blood pressure questions or the role of public health departments?
Was a specific question related to blood pressure?
Well, there was more than one. There's one I see in front of me here about recommending an app for home monitoring, but there were others as well, I think.
There's loads of apps available for this. The bottom line is average home blood pressure readings are not just safer as a guide to managing hypertension, which, by the way, is the biggest of all risk factors, probably even bigger than smoking. And certainly in a diabetic patient, far bigger than smoking, far bigger than HbA1c. It is far more reflective of cardiovascular risk than clinic readings. But you need to take at least 14 readings, in my opinion. Because if you look at the data, that's when you average out 14 home blood pressure readings, then it becomes very accurate. I mean, if I had hypertension, I would be mortified if my GP just took 1 or 2 clinic blood pressure readings, condemn me to lifelong treatment, affecting my life insurance, travel insurance, recoding me with hypertension. I'd say, where's my, aren't you going to base it on a lot more readings? I mean, the ideal scenario would be a 24-hour blood pressure, because that also looks at nocturnal readings. But everyone should have the ability. I mean, the machines, how much are they now from Amazon? £20 for a very basic validated machine. That should be the standard of care now. And I think hopefully post-COVID, that will now, I think it should be unacceptable to recode hypertension on the basis of clinic blood pressure readings. We should now be promoting the virtues. And by the way, the reason why it's so important to screen for AF before you check someone's blood pressure is not only is AF the most lethal complication of hypertension, because it's a huge driver for AF, hypertension, B, it makes blood pressure readings, one-off blood pressure readings, completely invalidated, which even more reason to do far more home blood pressure readings. In an AF patient, I would suggest you need 28 readings, because the beat-to-beat variability of your QRS complex is so high in AF, can vary by up to 25%. So blood pressures can vary by 20 millimeters of mercury, depending on which beat you've measured it. So for AF patients, it's important to screen these patients, because it means that your hypertension reviews need to involve far more home readings averaged out. So for a variety of clinical quality reasons, we've got to be screening for AF in these patients. And by the way, there's a couple of questions on the 1 lead AliveCor, which is a phenomenal device. I loved it, but I do think for efficiency and streamlined and leaner pathways, the 6 lead has the edge, because it's diagnostic quality. I don't have to have a 12 lead confirmation of my 1 lead AliveCor trace. And it's just been a game changer in my personal practice. I might want to get a 12 lead ECG to look at the whole sort of clinical picture of the patient. But in terms of anticoagulating and diagnosing AF, that's enough. Plus it's Bluetooth technology, which I don't care what the manufacturers say, is far less noise in most patients and cleaner trace than you get with the original. So the original was great, but this is just, for me, a massive stepwise increase in quality and hugely more streamlined pathways.
Thank you. So I'm watching the number of users. They seem to be going down now that the clock's turned 2 o'clock. So what I'll do is I'll go to each of you for one last comment, point, question, answer, and then we will close up at that point. So Sean, I'll start with you.
I think the main thing from my side is obviously we're trying to identify as much as we can how we can support cardiac abnormalities as well as heart failure. So looking at arrhythmias in the situation of where patients cannot access ECG or they need immediate access. We spoke about briefly in regards to the patient time and challenges, and we hear so many times of people who are symptomatic, but their arrhythmia or their disease has not ever been captured. Well, we're giving the opportunity for people to do that. So please embark on technology, look at this, and hopefully we can make a difference to support with that.
Thank you. Yasser, final words from you?
I guess for me, it's just a reinforcement of the importance of not taking your foot off the pedal with our patients with chronic disease and cardiovascular disease. We must be fully aware that the excess mortality is going to be multiple folds more from suboptimal chronic disease management than COVID-19. And I think the safest, most efficient way of trying to address this excess mortality is we have to adopt the technology. That's the only way. And once you've adopted it, I think it's here to stay. This is not just a temporizing measure. This is going to be here to stay for the long term, for the benefit of all of us.
Thank you. And Nikki?
I think that, following on from Sean and Yasser's comments, patients live in all kinds of places. And when I say live, what I mean is they go to the dentist, they go to the opticians, they go to the podiatrist. They don't always just go to the GP surgery. So it's about taking that wider view and looking at where, if we've captured those patients who we've diagnosed with AF, that is great. But those people that are missing, where are they hiding out? And we need to go there and find them there.
Don't forget Asian weddings. I'm telling you, it should be mandated to have a AliveCor booth in an Asian wedding, in my opinion and experience.
Thank you. So before I thank everybody, just a bit of a reminder. So cardiovascular disease, clearly one of our biggest killers and our biggest cause of health inequality. Not only does it impact on people's health, but we know that long-term conditions are also related to economic productivity as well. In terms of our long-term plan, cardiovascular disease prevention is one of our top priorities, and atrial fibrillation, blood pressure and cholesterol are the key things that we're focusing on. So I will thank our speakers in terms of Sean Warren, Yasser Javed and Nikki Holsworth, and most of all, I'd like to thank the audience for having taken the time and trouble to tune in. And at this point, I will say goodbye to everybody and wish you all a good afternoon.
Thank you very much, all. Have a good day.
Take care. Bye.
Bye.